Hi everyone. So today we are going to discuss the use of Mycophenolate Mofetil in dermatology. This will be a bit shorter presentation because there's not much to MMF. We must know how it acts and what is its mechanism of action, and we'll be able to use this drug more effectively in our patients. It's more of a safer drug. The adverse effect profile is much better than as compared to other immunosuppressives, and it's better if you have a patient who requires immunosuppression for a prolonged duration. If possible, shift them to MMF. The only inhibiting factor is its cost. So we'll discuss MMF in a shorter detail, and subsequently we'll be able to be much more comfortable with this drug. Okay, so remember that MMF is a prodrug. Okay, it's a prodrug which gets converted into mycophenolic acid, and this mycophenolic acid is the active component which leads to immunosuppressant effects. So MMF gets converted into mycophenolic acid. So I'll be using MMF converting into MA. It is derived from the fungus Penicillium stoloniferum, and it's because of fermentation product that we get mycophenolic acid and subsequently MMF. It's available as capsules, tablets, oral solution, and also an enteric coated one. Now remember that in enteric coated tablets, the dose required is a bit smaller one. For example, roughly 720 milligram of enteric coated is equal to 1000 milligram MMF. So just remember that if you are using the enteric coated one, the dose required will be towards the lower side. Now, mycophenolic acid was found to have antibacterial, antiviral, antifungal, anti-tumor properties. Additionally, it also had immunosuppressive properties, but its use have now been discontinued because it was associated with many adverse effects. So mycophenolic acid was associated with many adverse effects. So now we are using MMF, which is a prodrug for mycophenolic acid. MMF was developed, it had greater bioavailability, tolerability, and because of that it received the FDA approval for use in organ transplant patients. So like all immunosuppressive, MMF was initially approved for organ transplantation. The response is towards lower sides, taking around 6 to 8 weeks to properly act. The dose is roughly around 1 to 2 gram per day in divided doses. That means you start with 500 milligram a day, then increase to 500 milligram twice a day, then 1 gram in the morning, 500 milligram in the evening, then 1 in divided doses. So you can reach to a level of 2 gram every day, but divide the doses. You can also use 500 milligram 4 times a day. So just make sure that the doses are divided. Okay. Into pharmacology of MMF. MMF is what is known as cycle-specific antimetabolite, somewhat similar to azathioprine. And like azathioprine, it is an inhibitor of purine metabolism. Now we know that purines are adenosine, guanosine, so this gets inhibited. Predominantly, it decreases the level of guanosine, leading to decreased formation of DNA, leading to decreased proliferation of cells, and because of that it acts as an immunosuppressive because it selectively decreases the lymphocytes, T and B lymphocytes. How does it selectively inhibit T and B lymphocytes? We'll learn about that in subsequent slides. Okay. On oral intake, it is 80 to 90% absorbed. Peak plasma level occurs in two peaks. First peak is 1 to 1.5 hours, and that is correlated with the oral absorption. The second peak is correlated with enterohepatic circulation. Now what happens is that MMF gets converted into mycophenolic acid, which gets converted into MPAG. Now MPAG is inactive, but it binds to bile, and because of bile it goes into enterohepatic circulation. That means the molecule gets circulating between hepatic hepatic blood circulation and intestines. So in liver, MPAG bile compound gets secreted into intestine by subsequent biliary secretions and then reabsorbed through intestine and goes back to liver. This is known as enterohepatic circulation, and because of this enterohepatic circulation, we see the second spike of peak plasma level at 6 to 12 hours. It is more than 97% protein bound, and the free less than 3% is responsible for activity. So remember that if your patient has less protein, let's say any other case of hypoalbuminemia, it will lead to more MMF or rather more free MMF, and this might lead to side effects and toxicity. So keep that in mind also. Half-life is roughly around 16 to 18 hours. Now, MMF is what is known as 2-morpholinoethyl ester of mycophenolic acid. Remember that mycophenolic acid is the active component. MMF is rapidly absorbed and gets converted in plasma, liver, and kidney to MPA, which is the active component. MPA in liver undergoes glucourination. Just excuse my stupid pronunciation, but just remember I'm talking about this word. Gets converted to MPAG, which is inactive. And because of intrahepatic circulation bile, it keeps on circulating between liver and intestines. Okay. Now MPAG, which is inactive, under the influence of this enzyme, beta glucuronidase. Let me just slow it down. Beta glucuronidase. Seriously. Beta glucuronidase enzyme gets converted back to mycophenolic acid, which is the active component. Now, this enzyme is high in the epidermis and GI, which might be able to explain that why we have good skin-specific immunosuppressive action of mycophenolic acid. Okay, so just remember that this enzyme is responsible for conversion of MPAG to MPA, and it is mostly or in high concentration found in epidermis and gastrointestinal tract. The excretion takes place through kidneys, and more than 90% excretion is in the form of MPAG. Now remember that MPAG is the inactive metabolite, so there is no effect on MPA or the active metabolite. That means that in patients who have significant kidney dysfunction, or not even significant, let's say mild kidney dysfunction, MMF becomes a very good drug. It is not nephrotoxic, so second important point why MMF is a good drug in kidney patients, and it does not cause it gets it does not get excreted via kidneys as an active metabolite. So when MPAG gets excreted, the MPA levels, and remember that that less than 3% is required for its active efficacy. The rest 97% is bound to protein. So this protein thing gets dislodged and it forms more mycophenolic acid. So this MA gets continuously replenished. So the efficacy is not that much reduced in patients who have dysfunctional kidneys. So it becomes a bit safer drug to be used in patients who have renal dysfunction. The doses also need not be modified in patients of kidney disorders. Mechanism of action. Remember that Mycophenolate Mofetil or MF is a purine metabolism inhibitor. It non-competitively binds and inhibits IMPDH. Now what is IMPDH? It is inosine monophosphate dehydrogenase, which is a key enzyme of de novo pathway. Okay. Now, just a refresher, during purine synthesis, you have two pathways. You have de novo pathway and then your salvage pathway. De novo pathway is like buying a new car. You need to have a lot of money, but you will get a new car with you. Salvage pathway is like buying a second-hand car. You buy a second-hand car which is already being used for subsequent time, repair it, and make it functional, and then use it for your purposes. So salvage pathway takes care of other preformed compounds and converts them into purine. De novo pathway forms purine from scratch. Now what happens is that leukocytes or the T and B cells are dependent entirely on de novo pathway. They don't have a good functioning salvage pathway. Normal cells have both pathways. So because of that, they are able to make purines if one pathway gets blocked. IMPDH is a key enzyme of de novo pathway. So if this enzyme gets blocked, normal cells can form normal purines with salvage pathway, but T and B cells don't have that good functioning salvage pathway, so their DNA synthesis gets blocked, leading to decreased proliferation of T and B cells, leading to immunosuppressive effects. So leukocytes who are entirely dependent on de novo pathway are selectively inhibited by MMF. Additionally, MMF prefers leukocyte isoforms. Now there are many isoforms of IMPDH and MMF selectively prefers those isoforms found in leukocytes. Clear? Other than that, VCAM1, vascular cell adhesion molecule, E-selectins and P-selectins are also inhibited by MMF, and this leads to decreased diapedesis and migration of lymphocytes through the endothelial cells of blood vessels at the site of inflammation. So just to revise that, if let's say these are the endothelial cells and this is a gap in between endothelial cells, the migration of inflammatory cells through this gap is known as diapedesis. The cells squeeze through those gaps, and MMF blocks E-selectin, P-selectin and VCAM, leading to decreased adhesion of these leukocytes to the endothelium cells and decreased migration of cells through the endothelial gaps into the skin where inflammation is taking place. Now, blockage of de novo pathway is the main mechanism of action. Other mechanism of actions are somewhat minor. Other actions are the decreased dendritic cell activation, it decreases antibody production by B cells, and it decreases fibroblast activity. Decreasing fibroblast activity can explain the decrease in tissue fibrosis and its use in fibrosing disorders like scleroderma or systemic sclerosis. Just to revise quickly, you have two pathways of purine synthesis. You have de novo pathway and your salvage pathway. Now, how does de novo pathway work? It just takes all the molecules and reaches the compound inosine monophosphate. Now, this inosine monophosphate, under the action of inosine monophosphate dehydrogenase, gets converted into guanosine monophosphate. This guanosine monophosphates get converted into deoxyguanosine diphosphate, which subsequently forms DNA. Now, this is the normal de novo pathway. This is the normal de novo pathway. Okay. What mycophenolic acid does it blocks IMPDH. So this pathway cannot go further. There is increase in inosine monophosphate, there is decrease in guanosine. Clear? Other cells also have salvage pathway. Now salvage pathway can form guanosine by utilizing other molecules, and because of that, for example, we can see that it can utilize guanine and use HGPRTase to form guanosine monophosphate. Okay. Now other cells can use salvage pathway to form purines, but since leukocytes are dependent on de novo pathway, they are not able to form guanosine, and this leads to no DNA. This leads to apoptosis of cells. Clear? So now we know why MMF selectively inhibits proliferation of lymphocytes. So just to recapitulate shortly, that de novo purine synthesis in T and B lymphocytes, they form inosine monophosphate. Under the action of IMPDH, it forms guanosine and various other purines. This enzyme, which is IMPDH, gets blocked by mycophenolic acid, and this mycophenolic acid blockage does not lead to formation of guanosine, and there is decreased DNA synthesis. This leads to decreased proliferation of inflammatory cells and decrease inflammation. Other cells can use salvage pathway but not lymphocytes. Now, indication of MMF. Remember that MMF has only been approved by FDA for its use in renal transplant patient. So all other uses are non-FDA approved. Clear? Now, remembering the indication is easy. All you have to remember is the heading. So, dermatitis, bullous dermatosis, and autoimmune connective tissue disorders. Okay. So, dermatitis and papilloscopic disorders like psoriasis, atopic dermatitis, dyshydrotic eczema, chronic actinic dermatitis. Two other disorders like Parthenium dermatitis and airborne contact dermatitis are important in Indian scenario. Bullous disorders like pemphigus vulgaris, foliaceous, bullous pemphigoid, cicatricial pemphigoid, paraneoplastic pemphigus. Other bullous disorders like epidermolysis bullosa acquisita, linear IgA bullous disease. MMF has been used in all of these dermatosis. There are multiple case reports in that. In autoimmune connective tissue disease, in SLE, SCLE, chronic LE, chilblain LE, diffuse systemic sclerosis, I told you that it decreases fibrosis. So because of that, it can show additional benefit in diffuse systemic sclerosis. dermatomyositis. It has been used in all of these disorders. Now, vasculitis like venous granulomatosis, microscopic polyangiitis, Churg-Strauss, Behcet syndrome, MMF has been used in these disorders. Other miscellaneous disorders are pyoderma gangrenosum, cutaneous Crohn's, sarcoidosis, recurrent erythema multiforme, or ENL. There have been isolated case reports of using it in ENL. Necrobacil lipoidica, chronic urticaria, lichen disorders like lichen planus, lichen planopilaris. Now, there have been isolated case reports of its use in these disorders. So, just to complete the list, you just have to remember the headings: vasculitis, miscellaneous dermatitis, papillosquamous disorders, autoimmune disorders, and bullous disorders. Just remember these 5 words, and you'll be able to easily fill the page with examples. Now, just few additional points regarding the use of MMF in various disorders. In psoriasis, the efficacy is found to be similar to methotrexate. It can be used in generalized flare or pustular psoriasis, but remember that MMF takes some time to act. It's better to control the disease activity by using a faster immunosuppressive like cyclosporin, and then maintain the patient on MMF. There have been reports of its use in HIV positive patients who are retropositive and taking ART therapy. If they also have psoriasis or any other disorders from the list, MMF can be safely used. It is last line therapy for psoriasis. Now, last line doesn't mean that MMF works where other drugs are not showing any response. It just means that it's a safer drug to act for a longer duration, so you can maintain the patient for a prolonged duration on MMF. The use of MMF in immunobullous disorders is predominantly because of its corticosteroid sparing effects. Now, this is very important. So, whenever you have a patient, and we know that most of the patients of immunobullous disorders require treatment for a prolonged duration, MMF becomes a safer and a good drug for the patient to be put on. Over long term, the corticosteroid sparing side effects have found to be better than other immunosuppressives like cyclosporin, cyclophosphamide, or azathioprine. So it's better to maintain the patient on MMF. It shows faster sustained remissions when given with steroids. That means you have to initially control the disease activity of steroids. Then while you are tapering steroids, add MMF so that it can be easily used to maintain the patient for longer duration. The clinical efficacy are found to be similar to other immunosuppressive, and the efficacy of MMF is better in psoriasis has found to be better in immunobullous disorders as compared to its efficacy in psoriasis. These are just the list of bullous disorders which we have also previously seen in last slide, and we can just re-enumerate them. Other causes like the use in LE, DLE, SCLE in dermatomyositis where it shows good lung improvement, and also there have been case reports of good improvement in amyopathic dermatomyositis, which is anti-MDF5 antibodies positive. Vasculitis, predominantly ANCA positive vasculitis. Systemic sclerosis, I've already said that it decreases fibrosis, leads to good skin and lung improvement. Atopic dermatitis, and it can be used for as an option for severe disease. So you control the disease activity, make it manageable, and then maintain the patient on MMF. Contraindications. Like all drug, hypersensitivity to MMF, mycophenolate sodium, mycophenolic acid, or any other component of formulation is an absolute contraindication. The patient will land in severe drug reactions. Box warnings include that the physicians which are experienced in use of MMF should use it. Prolonged immunosuppression or use with other immunosuppressive agents have been linked in increased lymphomas and increased skin malignancies. However, I'll just say again that these side effects have been reported in patients who are taking drugs for organ transplantations. The doses for inflammatory dermatosis, is towards the lower side, and because of that, we must keep an eye out for these kind of malignancies during our physical examination of the patient. But the report of skin malignancies and lymphomas are not that much in skin dermatosis. It can lead to activation of infections and also embryo-fetal toxicity. We'll discuss that later in subsequent slides. Warnings, we just have to remember the heading. Infections like opportunistic infections, viral, bacterial, fungal, protozoal, they can be reactivated in patients. Reactivation of hepatitis B, C, JC virus. Now, JC virus is John Cunningham virus, and reactivation of JC virus can lead to progressive myeloleucoencephalopathy, and this can be fatal, so we have to keep that in mind. Any immunosuppressive, be it MMF or azathioprine or methotrexate or cyclosporine, if this reactivation of JC virus, this has been linked with PMLE, which is fatal, so we have to keep in mind. Avoid MMF with live vaccine like any other immunosuppressive. So we can say that all of the contraindication, warning and precautions are same as other immunosuppressive. Malignancies like lymphomas and skin malignancies are found to be higher in transplant patients, not for skin. In blood, it decreases all these rapidly dividing cell lines because of its effect in cell proliferation. So all these cell lines like neutrophils, RBCs, they all get decreased. GI symptoms or GI side effects like nausea, vomiting, diarrhea occur like any other drug. Avoid with Leishman syndrome. Why do we have to avoid with Leishman syndrome? Because Leishman syndrome is HGPRT deficiency, and HGPRT deficiency is a very important enzyme in salvage pathway. So if you block the de novo pathway with MMF and you block the salvage pathway with during Leishman syndrome, all the cells of the body do not have a mechanism to form purines. DNA synthesis will not take place properly, and it will be very detrimental to patient. Now, older pregnancy category is category D. The newer one is moderate to high risk. So, if in Viva you are asked the pregnancy category of MMF, the answer is moderate to high risk. Adverse effect, you just have to remember the headings. So, we'll just remember the heading. Hematological are dose dependent, all cell lines are decreased, neurological weakness, fatigue, headache, and also theoretical risk of increasing progressive myeloleucoencephalopathy, PMLE. So that should also be mentioned. Teratogenicity is linked with first trimester loss and ear and mid facial abnormalities. Okay, so in embryo we see what is known as mid facial abnormalities. Okay, carcinogenicity, theoretical risk more in more in organ transplant patients, somewhat lesser in the doses we use. The malignancies are lymphomas, EBV lymphomas, B cell lymphomas, and skin malignancies. GI are dose dependent. Genitourinary can lead to urgency or decrease in frequency. Remember that MF does not cause nephrotoxicity. It is somewhat safer immunosuppressive drug in patients with renal dysfunction. Infections like viral, bacterial, and atypical mycobacterial fungal can occur, and they are more common in transplant patients or patients who are using immunosuppression for prolonged duration, or patients who are using other immunosuppressant concurrent with MMF. Just a few salient points regarding individual adverse effect. For example, in malignancy, I've told that it is more common in transplant patients, and lymphomas, B cell lymphomas, EBV associated lymphomas, particularly in patients of South Asian or Southeast Asian descent, are important. We need to be on clinically, we should look for this kind of lymphomas. And if these malignancies do occur because of prolonged immunosuppression by MMF, they regress after stopping the drug. GI side effects are the most common side effects seen in 20% of patients, and out of nausea, vomiting, diarrhea, diarrhea is the most common GI side effect. These side effects are dose related, and whenever the side effects are dose related, it's better to decrease the dose or divide the dose. Let's say you're using 1 gram twice daily with significant GI side effect, it's better to divide it into 500 4 times a day, or 1 gram in the morning, 500 in the evening, 500 in the night. Give that in divided doses. The side effects are reduced if taken with food, and with subsequent usage of same drug and same dosage, these GI side effects tend to improve. So we can give it for prolonged duration if they are much more manageable. Remember that it is less hepatotoxic than azathioprine. Now, azathioprine is significantly hepatotoxic. Rising OTPT levels or rising or transaminitis is an indication for stopping azathioprine if it rises more than 2 times the upper limit. Okay. This is less hepatotoxic as compared to azathioprine, making it again a safer drug for prolonged use. Infections are more common when high doses are used or it is used with additional immunosuppressives. Okay. Hematological side effects. Remember that there is decreased DNA synthesis on MMF, so all cell lines are decreased, causing agranulocytosis, neutropenia, anemia, thrombocytopenia, lymphopenias. Two additional points that Wolverton mentioned is pure red cell aplasia. It's a rare disorder, and most commonly it is seen when other immunosuppressants are being used. Clinically, it is seen with fatigue and tachycardia. So we just have to see the cell lines and cell counts when we have clinical complaints of fatigue and tachycardia. Another is pseudo-Pelger-Hewitt anomaly. So remember that in neutrophils, you have multiple lobes. Roughly count is around 3 to 5. Now these lobules are decreased in pseudo-Pelger-Hewitt anomaly. So that is known as nuclear hypolobulation. It leads to neutrophil dysplasia. That means multiple immature neutrophils are found in circulation which are not doing their job, and this leads to left shift on CBC. So in complete blood count, if this is the neutrophil distribution, it shifts to the left hand side like this. Let me use another color. So if this is the normal one, if this is the normal, so it gets shifted towards the left hand side. That means much more immature neutrophils are seen in circulation. Clear? It is dose related and it's reversible on stopping the medications. Discussing about few important points regarding the use of MMF in pregnancy. So MMF is category D as per the older classification of safety of drugs in pregnancy. The current classification is moderate to high risk. So if in Viva you're asked about the pregnancy classification of MMF, it is moderate to high risk and it is associated with first trimestral loss. And predominantly the deformities that occur are ear and facial deformities, distal limb abnormalities, heart and kidney anomalies. Additionally, esophageal abnormalities have also been reported with MMF. So just to remember, MMF, malformations of the middle face. This is known as MMF embryopathy. So middle face malformations like those involving ear, eye, lip and palate abnormality. So all the mid-facial structures are deformed when MMF is taken during pregnancy, and that is known as MF embryopathy. So you can remember it as malformations of the mid-face. So because of that, UPT before and during therapy is warranted. So before starting any immunosuppressive, it's a good idea to at the minimum know about the menstrual history, and at the most you should have a documented UPT before starting and also during the therapy so that you may prevent any unwanted fetal malformations. Now contraception is advised 4 weeks before starting MMF and 6 weeks after stopping MMF. So you start contraception and after 4 weeks you can start MMF, and after stopping MMF for an additional 6 weeks the contraception has to continue. So contraception has to continue for the entire duration. Okay, let's remove this. Okay, now hormonal contraceptives, predominantly those which has levonorgestrel, you have to be a bit more careful while using both of these two drugs together, because MMF decreases the levels of levonorgestrel. Okay, so if the patient is taking OCPs which is predominantly working via levonorgestrel, if we give MF, the levels of LNG decreases and it may not be that efficacious. So it's always advisable either to switch from levonorgestrel to non-levonorgestrel containing OCPs. Additionally, use two different types of contraceptions. So two different types of contraceptions have to be used for 4 weeks before till 6 weeks after the duration of therapy by MMF. Now, whether it is secreted in breast milk or not, or it causes any malformation in infants, that is not particularly notified in literature, but it's always better to avoid the drug when your patient is lactating, because we know that it is associated with fetal first trimester losses. So during the formation of organs, it does lead to a defect in those formation, and in a growing infant, it's better to avoid these kind of drugs. So if your patient is a lactating mother, it's a very important and very necessary for you to maybe consider some other therapies or modalities. Now, drug interaction. Drug interactions, we'll just discuss some common one. For example, NSAIDs and narcotics leads to increased seizures. The mechanism is unknown. Just remember that use with narcotics, use with phenytoin, use with NSAIDs leads to increased risk or increased chances of seizures. Using with other immunosuppressants can lead to increased chances of lymphomas, increased chances of infection, and additional side effects. Vaccines like live attenuated will lead to reactivation of the infections from the vaccine, and also killed vaccine when given along with MMF therapy has found to show less seroconversion in the patient. Okay, so it is advised to immunize at least 2 weeks prior to MMF usage. Other important are antivirals, which compete for MMF or mycophenolic acid for renal excretion, and because of that, the mycophenolic acid levels increases, leading to toxicity. Other important one are that azathioprine, when combined with MMF, can lead to severe or more immunosuppression. So you have to be a bit more careful while using these two agents together. Okay. Additionally, MMF has found to increase the level of cyclosporin. So, whenever you're using cyclosporin to counteract the initial disease activity and you are in stage 2 of changing of immunosuppression where cyclosporin is overlapped with MMF, remember that MMF can lead to increased levels of cyclosporin A. So, we have to decrease the dose a bit faster as compared to its use with other immunosuppressive when we are using cyclosporin A with MMF. Antacids. Now, MMF requires gastric acid for proper conversion to a mycophenolic acid. So, if gastric acid is neutralized by using various antacid, this conversion doesn't take place. And remember that this is the active moiety. So, we need proper conversion from MMF to MPA. Antiretroviral drugs like nevirapine. So nevirapine has been specifically mentioned that MMF reduces the level of nevirapine. This side effect has not been shown with other ART drugs. Nevirapine is one specific drug, so it's good to remember that MMF therapy decreases the level of nevirapine, thereby decreasing ART level or HIV suppression. So we have to keep that in mind. We have discussed about decreased level of levonorgestrel. Additional points to keep in mind is that calcium decreases absorption of MMF, so we have to keep minimum 1 hour gap between calcium and MMF. Iron supplementation has no effect on MMF, so iron can be given with MMF. Okay. Now, how to monitor the drug? Monitor from baseline means complete physical examination. Keep a baseline of any non-skin malignancies. What non-skin? Skin malignancies and lymphomas and other should become a part of your clinical examination. Laboratory monitoring includes CBC, LFT, KFT, viral markers and hepatitis BC panel, PPD to rule out active TB infection. Follow-up is to be done every 3 to 6 months with physical examination, look out skin malignancies and also response to MMF. Lab investigations whenever we are increasing dose. So in the first slide or second slide, we have told you that you can start by 500 milligram and increase it to once a day to twice a day, then 1 gram once a day to twice a day. When the dose is increasing, the monitoring is every 2 to 4 weeks. When the dose stabilizes and we are using the same dose again and again, the monitoring can be done every 2 to 3 months. Additionally, remember that UPT should be performed. So these are other monitoring modalities which should be kept in mind while using MMF. Okay. So with that, I'll end my presentation on MMF. If you have any queries, suggestion, any other doubts, you can email me anytime on this email ID, or you can mention these doubts just below in the comment section so that I can read them. If there are any other questions that you have been asked during your vivas and you don't know the answer, it's better to share so that we can share the answers if we know and everybody learns in the process. Just to recapitulate, that MMF is somewhat a safer immunosuppressant drug. The only problem is that the suppression takes some time. The efficacy in suppressing the immunity is, if not inferior, to maximum same as other immunosuppressive drugs, and it's a bit towards the costlier side. So it's better to discuss all the modalities with your patient and then decide on a suitable immunosuppressive drug, and MMF can be one of them. Remember that it is a bit slower acting, so it may not be able to control the initial disease flare or initial disease activity. It's better to control disease activity with cyclosporin or systemic steroids and then maintain the patient on prolonged immunosuppression by using MMF. So I hope this presentation was a bit beneficial, and now we are slightly more comfortable in using MMF in our patients. Thank you.